To improve oxygenation, we have to understand gas exchange, which is the delivery of oxygen from the lungs to the bloodstream and the elimination of carbon dioxide from the bloodstream to the lungs. Gas exchange occurs during the inspiratory phase. The process of diffusion occurs, resulting in increased oxygenation. The alveoli then reduce in volume during expiration to remove carbon dioxide. Diffusion occurs during inspiratory time, which is essential for gas exchange. The expiratory time is about twice as long as inspiratory time. This gives an IE ratio of 1 to 2. The main determinant of oxygenation is the mean airway pressure, which closely reflects the mean alveolar pressure. Mean airway pressure can be increased by a variety of maneuvers. For example, elevating PEEP or increasing inspiratory time. Increases in inspiratory time lead to inverse ratio ventilation. Inverse ratio ventilation improves oxygenation as well as alveolar recruitment. However, due to the relatively short expiratory phase, the risk of air trapping is high. Inverse ratio ventilation increases oxygenation by increasing mean airway pressure, which has the additional consequence of increasing average intrathoracic pressure, reducing venous return, and reduce cardiac output. With conventional modes of mechanical ventilation, inverse ratio ventilation can be significantly uncomfortable, and patients may need to be heavily sedated to achieve patient-ventilator synchrony. Some inverse ratio ventilation modes, like APRV, allow spontaneous unassisted breath throughout the respiratory cycle. Airway pressure release ventilation is a continuous positive airway pressure with an intermittent release phase. The application of CPAP for a prolonged time maintains adequate lung volume and alveolar recruitment. There is a time-cycled release phase to a lower set of pressure for a short period of time, where most of ventilation and CO2 removal occurs. If patient has a spontaneous respiratory effort, spontaneous breathing can happen at any time, regardless of the ventilator cycle. If the patient has no spontaneous respiratory effort, APRV becomes typical of inverse ratio pressure-limited ventilation. In summary, APRV is inverse ratio pressure-controlled intermittent mandatory ventilation with unrestricted spontaneous breathing based on the open lung approach to ventilation. The major advantages over other modes of conventional ventilation are the preservation of spontaneous unassisted ventilation throughout the entire ventilatory cycle, maintenance of relatively long inflation time, and potential lung protective benefits. In general, the non-dependent regions of the lung receiving the most ventilation. At the same time, dependent areas receive the greatest perfusion. Maintaining spontaneous ventilation provide ventilation to dependent lung regions that receive the greatest blood flow. As a result, improve ventilation perfusion matching by a marked decrease of intrapulmonary shunt. Preservation of spontaneous unassisted ventilation will also maintain the normal cyclic decrease in pleural pressure, which augment venous return and improve cardiac output. Furthermore, preservation of spontaneous ventilation reduces the need of sedation and maintains diaphragmatic muscle condition. The second advantage of APRV is prolonged T-high, or prolonged inflation time, which is presumed to achieve the treatment goal of alveolar recruitment. It allows time for inflation of the slow lung unit in a non-homogeneous lung field. Furthermore, Longer inflation times promote collateral ventilation. The lung protective benefit of APRV is more theoretical, depends on the selection of setting to ensure ventilation on the safe zone portion of the pressure volume curve. Long inflation time results in less frequent inflation and deflation, which can contribute to shear stress on the alveoli.